Chapter 16 will discuss disorders of brain function. There are several different conditions that can cause injury to the brain. Trauma, which we'll talk about with the different types of hematoma. This can also be caused by different tumors in the brain. We're not going to talk about any specific tumors in this course. And then another major contributor here is stroke, which we'll talk about both ischemic and hemorrhagic strokes. There are also metabolic issues and degenerative disorders, but we're going to mainly focus on traumatic injuries as well as injury to the brain from stroke. So there are also different pathways to brain damage that can occur. One is the effects of ischemia. So if blood flow is impaired to brain tissue, that can cause damage. Another is cerebral edema. So if there is swelling of the brain tissue itself, that can cause damage. And the final one is injury due to increased intracranial pressure. So if the pressures inside of the skull increase a significant amount above normal, that can also cause damage to the brain. So we're going to start by talking about the different levels of consciousness and giving some definition to what those look like. So one thing to understand is that arousal and wakefulness requires function of both cerebral hemispheres, so kind of both sides of the brain, as well as an intact reticular activating system, or the RAS. The content and cognition aspects of consciousness are determined by a functioning cerebral cortex. So again, the content and cognition aspects of consciousness. That's what's determined by the cerebral cortex. Any deficit in the level of consciousness usually indicates a direct injury either to the RAS, so the reticular formation, or to both cerebral hemispheres concurrently. So brain injuries that affect just one hemisphere unilaterally and don't affect the RAS, such as things like cerebral infarct, usually don't cause impairments of consciousness. Okay, so again, you need bilateral impairment or damage directly to the RAS to really change level of consciousness. If it's just unilateral without damage to the RAS, you usually don't see a change in level of consciousness. And so what do we mean by levels of consciousness? Well, the first level is full consciousness. This is where someone is awake, alert, and oriented to time, place, and person. They're able to comprehend the spoken and written word, and they're able to express their ideas normally. The next level is confusion. These people will be disoriented to time, place, or person. They may have memory difficulties, difficulty following commands. In the level of consciousness known as lethargy, these people may be oriented to time, place, and person, but they're very slow in their mental processes, very slow in their motor activity, slow to speech, and they still respond to painful stimuli appropriately. In obtundation, or when someone becomes obtunded, they respond verbally with maybe a word or two. They're arousable, but they need a bit of stimulation to wake up. They still will respond appropriately to painful stimuli. They can follow simple commands, but they appear very drowsy. Like if you're not stimulating them, they'll fall asleep. In a stupor, people are unresponsive except to really vigorous or repeated stimuli. They still respond appropriately to painful stimuli. They lie quiet with minimal spontaneous movement when they're not being stimulated. They may make like incomprehensible sounds. They may occasionally open their eyes spontaneously. And the final level is coma. These people do not respond appropriately to any stimuli. They're in a sleep-like state with their eyes closed, and they don't make any verbal sounds. And we typically use the Glasgow Coma Scale to place people into different levels of consciousness. So we'll look at that in a moment, but just a couple things to also note. Level of consciousness is an important indicator that we use in brain injury and disorders that damage the brain. because it's something that can really indicate a deterioration of condition. So it's important to know kind of some of the early signs and some of the later signs of reducing level of consciousness. So some of the early signs are things like inattention, if people start to become confused or disoriented, or if their responsiveness starts to blunt or slow. As consciousness deteriorates further, the person becomes even less attentive. They might become lethargic or agitated, and then they can progress to obtunded and even into coma if their condition isn't reversed. So as you recall, here's the Glasgow Coma Scale. So it's a 0 to 15 point scale. Well, actually, it's a 3 to 15 point scale that uses three separate areas of assessment. One is eye-opening, so spontaneous to sound to pressure or none. Verbal response, oriented, confused. Words, sounds, none. Or motor response. They can obey commands, they can localize to pain, they flex to pain, they abnormally flex to pain, they extend to pain, or there's no response. So can we use these to decide kind of different levels of consciousness? Usually we say below 8 on a Glasgow coma scale, so 7 and below would be considered a coma, and then 15, of course, would be fully awake and alert. And then you fall in different levels of either, fully arousable to coma, those like lethargy, confused, all those things based on what you see here, right? So maybe you have someone who's spontaneously opening their eyes, they can obey commands, but they're a little confused or maybe a little disoriented. Then that person would be about a 14 and would be maybe in the confusion area of a Glasgow coma scale. But if they only open their eyes to pressure, like to a lot of stimuli, they just make incomprehensible sounds. Um, and they maybe experience normal flexion. So that might be someone who's obtunded. So they'd have a 4, a 2, and a 2. So they'd be at about an 8. So that's about as poor as it can get, right below that level of coma. So that's how we kind of transfer the Glasgow Coma Scale assessments to those different levels of consciousness. So as people's brain function continues to deteriorate, there are other significant signs and symptoms or clinical manifestations that we can watch for outside of level of consciousness. And some of these are actually included in the Glasgow Coma Scale. So if you think back to what the pain response looked like, some of the lower levels on that were referring to how someone responds to pain with either normal flexion or abnormal flexion or extension. And so some of these will kind of clarify that. But we're going to start with the pupillary response. Although pupils may initially respond to light, they can become non-reactive, meaning they don't respond to light, they don't constrict with light, and dilated as brain function deteriorates. So you can kind of see that in like the second picture here of the pupils. That's might be what you see in someone with deteriorating brain function. And sometimes we see that bilaterally, and sometimes it's unilaterally. Bilateral loss of pupillary light response usually suggests like a brainstem lesion, something kind of in a more like serious or significant area. Unilateral loss of pupillary light response usually suggests optic or oculomotor pathway lesions that's only affecting kind of one side. But pupillary response is one of the major things we look at when we're considering how much brain deterioration we've seen. There's also abnormal flexion and posturing. So as coma progresses, noxious stimuli or painful stimuli can actually initiate rigidity and these abnormal postures. We refer to them either as decorticate or decerebrate posturing. This is an example of decorticate posturing where someone's arms kind of flex into painful stimuli. And the top picture is a decerebrate posturing where painful stimuli cause people to kind of extend or push their arms sort of out to the side, and kind of sometimes like you can see there's like a little flexion of the wrist as well. Um, it's decorticate is usually an earlier sign. They get like an extra point on Glasgow for this type of movement. This decerebrate posturing is a further deterioration. So this would be more like, a score of 2 or even 1 on that Glasgow Coma scale. So that's occurring because different motor tracks are being interrupted from further brain deterioration. When we see this kind of movement or this kind of posturing, these have very poor prognostic indications. So they're very poor prognostic signs. And what that means is that people who are posturing in this way, especially decerebrate posturing, are probably to a level of brain damage or deterioration of brain function that will be extremely difficult to reverse. So it would be very difficult to get back any normal motion, movement, speech, level of consciousness. These folks are in trouble. Okay. Other things that you might see in someone as their brain function deteriorates, there are several changes to respiratory response you might see as well, especially as that brain deterioration extends into respiratory centers in the brainstem. So it might start with a lot of like yawning or sighing, and then they may go into Cheyne-Stokes respirations. That's where they have their respiratory rate increases and increases and increases until they sort of like almost tucker out, and then they go into these apneic periods, and then the cycle starts again. They also might get what we call central neurogenic hyperventilation, where this kind of overall loss of respiratory control causes them to just breathe really, really fast and hyperventilate. They can also get ataxic respirations. So those are respirations that are uncoordinated and irregular. And the final step of deterioration would be apnea, where they don't breathe at all because that deterioration has fully extended into the respiratory centers of the brain. So some reminders of some terms: hypoxia and ischemia. These are important in things that damage the brain as well. So hypoxia is that deprivation of oxygen with maintained blood flow. So these folks still have good blood flow to the tissues of the brain. There's just not enough oxygen in it. So this happens if someone's exposed to things like reduced atmospheric pressure, carbon monoxide poisoning, if they're severely anemic, or there's some other reason why they're failing to oxygenate the blood. So things like, severe respiratory disorders, pulmonary embolism, those kind of things. And in ischemia, there is a loss or interruption of blood flow. And so that loss of blood flow can be focal, like one area of the brain. Um, one region of the brain is compromised in that case. So this is what happens maybe in a stroke. Or the ischemia can be global, where essentially, like in the case of MI, for instance, the cardiac output becomes so compromised that the blood flow to the tissues in the brain is not sufficient in that case. So another concept that's important to understand is the concept of intracranial pressure. So if we think about the head, remember that the brain itself and all of the fluids and tissues of the brain are fully encased inside of the skull. So they're encased in this just kind of hard box that doesn't expand. And so the pressure inside of that hard box needs to be maintained at a sort of consistent level. And for most people, that level or that amount of pressure inside of the head is 0 to 15 millimeters of mercury. So that's normal intracranial pressure. That's the normal pressure that we would typically see inside of the cranium or inside of the skull. Okay. But because the skull itself is just this kind of hard box, anything that increases any of the components inside of the skull can increase that pressure. So increased ICP or increased intracranial pressure is a common pathway for brain injury. If those pressures go up too high, it can obstruct like the cerebral blood flow to the brain, causing ischemia. It can start to press on and destroy brain cells. It can push or displace brain tissue. If you take a CT scan of someone with really increased intracranial pressure, you can see brain tissue that's just kind of pushed over to the side or pushed to the middle. And the structures within the brain itself are very delicate. And so any of that kind of increased pressure or pushing or edema can cause a lot of damage to those delicate brain structures. And so I mentioned it can be any of the components inside of the skull. So the things that are in there, in that cranial cavity, are blood, brain, and CSF or cerebrospinal fluid, which we'll look at a little bit more in a moment. But about 10% of what's in there is blood, about 80% is brain tissue, and about 10% of the capacity is cerebrospinal fluid or CSF. And so from the picture you can see over here, you can see like here's the skull on the outside. You also have cerebrospinal fluid that kind of surrounds the brain. And then you have blood vessels, both arteries and veins, and then you have the brain tissue. And so anything that increases any of those components, that increase can increase that pressure. So if the blood volume increases, like in the case of maybe a hemorrhagic stroke where we have spontaneous bleeding into the brain, or if we have a subdural or epidural hematoma, those things increase the blood volume and increase the pressure. It can also happen if the volume of cerebrospinal fluid increases. We're going to talk about a condition called hydrocephalus, where the normal cerebrospinal fluid can't drain out appropriately. It needs to circulate and drain from that cavity, and it does that kind of all the time. If something blocks that circulation and drainage, the CSF can start to accumulate inside of the head. You can see it here, it's kind of labeled in blue. And if that volume, if that CSF can't leave and can't drain, it starts to increase the pressure. And the final thing is if brain volume increases. So if something happens like cerebral edema, if there's damage where we get like widespread edema to the brain tissue, that can increase the pressure. If someone has a tumor inside of their brain, as that tumor grows, it can also increase the pressure inside the head. So intracranial pressure is important to keep low as well, because we talked about if intracranial pressure increases, it can obstruct cerebral blood flow. And it does that because there's a concept called cerebral perfusion pressure, or CPP. And it's the difference between the mean arterial pressure in the systemic circulation and the intracranial pressure. So we talked about mean arterial pressure a little bit when we talked about systolic and diastolic blood pressures, but essentially the MAP is a number we use to talk about how well the different tissues in the body are being perfused. So cerebral perfusion pressure is the measure we use to talk about how sufficient the blood flow is to the brain itself. And you need to keep CPP above a certain level to maintain good blood flow to the brain. CPP is MAP minus ICP. So in the body, if the MAP stays the same, if the blood pressure essentially stays the same, but the ICP continues to rise higher and higher and higher, it will compromise the cerebral perfusion pressure, which is the pressure gradient driving blood flow to the brain. And if that happens, as ICP increases and CPP drops, then we get reduced cerebral blood flow and damage to the brain tissue from that increase in intracranial pressure. So it's important to monitor people for increases in ICP, especially if they have any condition that might increase any of the things that are contained within that cranial cavity, to make sure that that's not happening, because again, it can severely compromise cerebral perfusion pressure to the brain itself. So what does it look like when someone's intracranial pressure is increasing? Well, one of the main ways we can watch for this is by carefully monitoring someone's level of consciousness. If level of consciousness starts to change or deteriorate, that is a very common sign and symptom of changes to increased intracranial pressure. Other things we might see, pupillary changes. So if pupils are becoming uh, less reactive or dilated, we might see impaired eye movements. Things like nystagmus may develop. If you note any of those posturing, those decerebral or decorticate posturing, those would be a definite sign of increased intracranial pressure. Changes to motor function. Patients may develop headaches. Seizures are possible. Vital sign changes, there's something called Cushing's triad. The systolic blood pressure often goes up. It makes sense in an attempt to kind of raise the CPP. We can make the blood pressure go up to try to overcome the ICP. That's pretty common. But then at the same time, we'll see a drop in pulse. So systolic pressure goes up, pulse drops, and then we also see changes to the respiratory patterns. So things like maybe Cheyne-Stokes respirations. Those often happen in a triad in patients with ICP increases. There also may be vomiting or changes to speech. If this happens in babies, especially babies without closed fontanelles, you might see those fontanelles start to bulge, and their head circumference might change. So if we have a kid we're monitoring for ICP changes, we may be doing serial um, measurements of head circumference. So I mentioned earlier hydrocephalus, but we're going to talk about it a little more. So this is an abnormal increase in cerebrospinal fluid volume in any part or all of the ventricular system. So inside of the brain are these cavities that are called the ventricles. There's one in the right and left hemisphere and one kind of back toward the occipital area, and they contain cerebrospinal fluid. And then the cerebrospinal fluid also circulates through the spinal cord and also kind of all around the brain. If for some reason that circulation stops, or if that flow is stopped, we can start to get enlargement of all of those compartments that normally contain CSF. And so that starts to increase the pressure inside the head and starts to push against the brain tissue. If this happens in infants, it may not cause a lot of signs and symptoms right at first, or maybe even any long-term problems because their fontanelles are still open. And so because those fontanelles are kind of these fissures in the skull are still open, their skull can actually expand, unlike an adult's. So the pressure has to get quite a bit higher in an infant to cause problems than it would in an adult where those fontanelles are closed. But in an adult, if there's acute onset of hydrocephalus, it can cause severe increases in ICP, headache, and vomiting. So why would this happen in an adult? Well, one of the common causes of hydrocephalus in an adult is anything that increases the pressure inside of the head for another reason, right? So if they have like a hemorrhagic stroke, or if they have subdural or epidural hematoma, if they have, like brain tumors, anything else that can press and compress the rest of the brain. It may also compress those compartments that move CSF through, causing it to build up inside the head. So what do we do about hydrocephalus? Well, if it's congenital, if someone is born with a lack of drainage of CSF, we can install something called a VP shunt. This is actually a VP shunt that you see in the picture. So one end of it sits in the ventricle in the brain, and then there's a shunt or a tube that actually empties out. It's tunneled all the way under the skin, and it actually empties into the peritoneal cavity. And so then CSF fluid just kind of drains into that cavity so it doesn't accumulate in the brain. If this happens to an adult, we can also use this procedure if it's like some blockage that we can't undo. But other things, if we can externally drain the CSF also, anything we need to do to kind of reduce that overall pressure and buildup of hydrocephalus. This slide kind of shows how the cerebrospinal fluid circulates. So I've been talking about it a little bit, but just to kind of give you a picture, I'm just going to play this little animation so you can kind of see it. So then we'll talk about some of the different types of hematomas that can form. Hematomas form in the brain, usually as the result of a brain injury. These brain injuries can be traumatic, so in the case of something like an epidural hematoma or a subdural hematoma, concussions, those kind of things, or they can be non-traumatic. And those things happen in the case of maybe a stroke, infection, tumor, or seizure. Epidural hematomas, subdural hematomas, and traumatic intracerebral hematomas are the ones that we're really going to talk about. And so you can see those depicted here. This is an epidural hematoma. This is an intracerebral hematoma. And this is a subdural hematoma. And what you should note is kind of the different sort of locations and the layers of the brain where these happen. An intracerebral hematoma is right inside of the cerebral tissue itself. A subdural hematoma occurs below the dura mater of the brain. An epidural hematoma occurs between the skull and the dura mater of the brain. And so we'll talk about kind of each of those types of traumatic hematomas. So with an epidural hematoma, again, that's this guy right here, it's usually caused by a head injury where the skull is fractured. So again, this is the skull right here. So if there's a fracture, that's when we get this kind of buildup of blood in that epidural space. And it develops between the inner table of the bone of the skull and the dura mater, which is the protective covering outside of the brain itself. Okay. So typically a person with an epidural hematoma has a history of some kind of head injury. And then a common course of this is where right after the head injury, the person will experience a brief period of unconsciousness, followed by a lucid period where they completely regain their consciousness. They seem pretty normal. And then it's followed sometime later by a rapid progression to unconsciousness. If a problem is identified, prognosis is really good if we can remove that hematoma surgically before the person loses consciousness significantly. If it's not removed and the condition progresses, it can cause a rapid increase in intracranial pressure and what we call tentorial herniation, where portions of the brain press out through different openings in the skull. So often, like there's an opening kind of down by the brainstem, it can push out. There's some openings kind of towards the side, temporal areas where it can push out. Once brain herniates, that person's prognosis is extremely poor, and usually death would be imminent. So epidural hematomas usually happen pretty quickly. They can progress pretty quickly because of the way that blood vessels are damaged. You can kind of see there's sort of a large blood vessel here that sort of becomes torn as that dura mater rips away. And so the bleeding that happens in an epidural hematoma can happen quite quickly. So again, if somebody has a brain injury or trauma to the skull, even if they lose consciousness, even if they regain it, they should be encouraged to seek medical attention to get themselves scanned because of that presentation that can occur with epidural hematoma. Subdural hematomas are usually the result of a tear in some small bridging veins. So this would be like an arterial tear and an epidural. In a subdural hematoma, they're usually small veins that are torn. And they're usually, again, bridging veins. So they're not big, like large veins. They're small veins that bridge some larger veins. Because those are what are kind of sitting on the surface of the cortex of the dural sinus to kind of drain blood flow. So a subdural hematoma develops in the area between the dura and the arachnoid space. So this is the arachnoid space right here. And they can be acute, subacute, or chronic. And that depends on the classification depends on how long it takes for someone to develop symptoms after that bleeding were to be initiated. In the case of something like an acute subdural hematoma, those usually progress really rapidly, and they have a relatively high mortality rate because of the severe secondary injuries of things like cerebral edema and increased ICP that can happen as that blood increases, right? So remember that ICP increases if any of the three components, blood, CSF, or brain tissue, increases. And so this would be an example of a significant increase in the amount of blood volume inside of the brain. So ICP can go up quickly, especially with a large subdural hematoma. And high mortality from these is associated with uncontrolled ICP increase. So we need to watch closely in these patients for changes or loss of level of consciousness. We need to monitor them for extension posturing, which might indicate a deterioration in blood in brain damage. And the best course of treatment here is to remove that hematoma before those severe signs and symptoms occur. Clinically, something like an acute subdural hematoma looks a lot like an epidural hematoma and the quickness of the progression, but there's usually no like lucid interval that we see in an epidural. So that can be really important to kind of the diagnosis and treatment, getting a good history of how the injury occurred. In the case of something like a traumatic intracerebral hematoma, there may be a single hematoma like you see here, or there may be multiple areas. Another thing to point out on this picture, so if you look at the intracerebral hematoma, these kind of lighter yellow things are the ventricles of the brain. And normally they are symmetrical. They just kind of sit right in the midline of the brain. And you can see here how they're being pressed over as that hematoma pushes brain tissue to the side and kind of displaces everything. So you can see little arrows showing displacement of brain tissue kind of all over. And remember when we talked about mechanisms that can damage the brain, right? One was ICP, but another is this pressing or pushing of brain tissue to the side, which damages all the little structures. So something to kind of think about too, as these areas of bleeding kind of press and push that and displace brain matter. But intracerebral hematomas, again, they can be a single, like we see here. There might be multiple areas. They can occur in any lobe of the brain, but are most common in the temporal lobes or in the frontal lobes. They're also more common in people who have fragile vasculature in the brain or easily damaged vessels. So in people like the elderly or chronic alcoholics would be people who are more prone to intracerebral hematomas. Now we're going to move on to discuss stroke, both ischemic and hemorrhagic type strokes. So inside the brain, there is an extensive network of blood vessels that supply the necessary blood flow to provide enough oxygen and nutrients to the brain tissue. I don't need you to kind of memorize all of these different structures, just to understand that there is, this extensive network of blood flow. Essentially, we have our two internal carotid arteries kind of anteriorly We have vertebral arteries that supply blood posteriorly. You can see those kind of right here, carotids right here. Internal carotids and vertebral arteries communicate at the base of the brain through something called like the circle of Willis that you can kind of see right back here. But again, I don't need you to memorize all of this. Just know that there's, this extensive network of blood supply. Another concept that's important to understand in the whole idea of cerebral blood flow or blood flow to the brain is autoregulation. So cerebral autoregulation is the ability of the brain to maintain a constant blood flow despite changes in systemic arterial pressure. So there are regulatory mechanisms that maintain good blood flow to the brain that are essentially independent mechanisms of what's happening in the rest of the systemic circulation. And so this is important to make sure that we maintain good cerebral blood flow, even if we have compromised or changes to the pressures within the rest of the system. Again, this concept of autoregulation. If blood pressure falls below 60 millimeters of mercury, however, even that autoregulation mechanism can't really keep up, and cerebral blood flow really becomes severely compromised. So when we're taking care of patients, if they have, hypotension that drops their systolic blood pressure below 60, understand that at that point you will have, even with autoregulatory mechanisms, you will have significant compromise of blood flow to the brain itself. There's also some impact of sympathetic stimulation here as well, which we'll kind of talk about. But there are a lot of metabolic factors that can impact blood flow to the brain as well. So if levels of CO2 increase, or if oxygen levels decrease, or if hydrogen ions increase, causing a more acidic environment, all three of those things, or all three of those metabolic factors, can lead to cerebral vasodilation, and that will increase the amount of cerebral blood flow. These are compensatory type mechanisms. So if O2 drops, we need to maintain oxygen levels to the brain, so we will increase cerebral blood flow. If carbon dioxide or hydrogen ions increase, we consider those harmful substances. And so by increasing blood flow, we can help to kind of wash those harmful substances away. So those are kind of the mechanisms behind why those metabolic factors will increase blood flow. And when we talk about autoregulation, those local regulatory and autoregulatory mechanisms can often really override the effects of things like sympathetic stimulation and the rest of the system. But sympathetic control of cerebral blood pressure also is important when things like local mechanisms fail. So if arterial pressure rises, like during the case of like strenuous exercise, and the sympathetic nervous system will then step in to kind of start constricting large and intermediate sized superficial blood vessels inside the brain. And that protects some of our smaller, easily damaged vessels during those times of high pressure. So again, to kind of describe that, right? Like if you're out exercising and you're getting your blood pressure and your heart rate up, and so all this extra blood flow is going to the brain, I mean, that's fine and not maybe necessarily harmful in kind of the large vessels, but you also have a lot of like really kind of small vessels inside of the brain that could be very easily damaged if that pressure goes too high. And the autoregulatory mechanisms that normally would take over are kind of sort of overwhelmed at that point by all that extra pressure. And so then the sympathetic nervous system would take over and cause some constriction to rapidly shrink those vessels so that we don't get damage to those little blood vessels that can't take that high pressure system. And that's a good thing. That's very protective, because if that didn't happen, you could potentially have a hemorrhagic stroke every time you would go out to exercise, right? So it's important to have mechanisms outside of that autoregulation when pressure rises really rapidly. So after those conversations, then we'll talk about the two kind of main types of strokes, or what we now sometimes term a brain attack. So the two types are ischemic strokes and hemorrhagic strokes. Ischemic strokes are caused by some type of interruption of the blood flow in the cerebral vessels. These are the most common type of stroke. 70 to 80% of all strokes are ischemic in nature. And the things that can block blood flow can be either coming from like large artery and small penetrating artery thromboses. So like our carotid arteries might fill with plaque and reduce the blood supply, so that can cause a stroke. Or they can be sources of some kind of emboli that can cause ischemic stroke. So like if we have an emboli that forms like somewhere in the left heart, that can cause a stroke. If we have aortic plaquing, those pieces can break off and cause a stroke. And cardiogenic emboli, those can move and cause a stroke. So any of those things can cause an interruption of blood flow in the cerebral vessels. In hemorrhagic strokes, these are caused by bleeding into the brain tissue itself, usually from a blood vessel rupture caused by either hypertension or an aneurysm that has formed, or by something called an arteriovenous malformation. They can also happen after head injury, or they can happen as the result of blood dyscrasia. So if somebody has maybe a severe um, uh, bleeding disorder, from like maybe a significant loss of like clotting factors or a significant drop in platelets, they can also experience a kind of spontaneous hemorrhagic stroke. So we're going to start by talking a little bit about ischemic strokes, then we'll talk about hemorrhagic, and then we'll talk about like the clinical manifestations that are sort of common to all types. So risk factors for ischemic stroke, these are very similar to the risk factors of any of our ischemic vascular diseases. So whether it's coronary artery disease, peripheral vascular disease, cerebral vascular disease, they all have really the same type of risk factors involved. So the incidence increases in age. They tend to be more common in men who are younger, but then become more common in women later in life. More common in usually African American populations. Family history, if you have a family history of stroke, you have a higher risk. If you have hypertension or if you smoke, people who are diabetic. Also people with asymptomatic carotid stenosis, so people who have plaquing or buildup of plaque inside of the carotid arteries that are increased risk, because that plaque can rupture and either form an emboli that goes up to the brain, or it can cause a thrombosis that blocks blood flow directly at the carotid site of plaquing. Also, people with sickle cell disease can experience ischemic stroke, hyperlipidemia, and then, of course, atrial fibrillation due to the formation of thrombi that can embolize to the brain in the left atrium. So with ischemic strokes, there are some ischemic stroke kind of warning signs and then some danger zones. So there are some things that like are warning signs of ischemia that maybe can cause us to initiate treatment to prevent any like further damage. So one thing to understand is something called an ischemic penumbra, and that's something we see in an evolving stroke. So if someone is having a stroke and damage is occurring at this moment, right? They develop something called an ischemic penumbra. And usually there's kind of like a core of dead tissue in the brain itself that's surrounded by like dying cells or cells that might still be functioning and still could be saved if we restore that blood flow. So that's kind of this early stage of flow, right? Where we lose blood flow. Some cells kind of at the core of this thing are initially killed because that blood flow has caused, significant damage. But as a stroke progresses, areas around that initial core can start to further die. And in the early stages, those cells are still probably salvageable as long as we do something kind of immediately to open up the blood supply to restore their blood flow. If we can do that, we can often save many of those brain cells. There's also something called a transient ischemic stroke or a TIA. This is kind of like brain angina, right? So when we talked about angina and coronary artery disease, it was kind of like a warning sign that heart tissue wasn't getting enough oxygen. And it kind of said to us, okay, this person has angina, there's not enough blood flow, let's figure out why and try to correct it. In the case of the brain, that warning sign, like angina, kind of takes the something called a TIA kind of takes the place of that angina symptom. And so people might come in with kind of signs of a stroke. So maybe like some slurred speech or confusion or facial droop or visual changes, some kind of disturbance, but it's temporary in nature. So those signs and symptoms will kind of completely reverse themselves, and people will not have any sort of residual damage or deficits after that. Everything is completely restored. So, but even though people go back to normal, we still need to investigate why that happened. So, we might look at their carotid arteries and see if there's stenosis. We might do an echocardiogram to see if there's any, left atrial changes that might indicate atrial fibrillation. So we would start looking for, potential causes of stroke in the case of TIA, so that we can correct those before a stroke were to happen, just like we would in the case of angina in the heart. The other concept here is something called the watershed zone. So when we think about the blood supply to the brain, if we block off perfusion, all of the areas kind of distal to that perfusion, any blood vessels that are kind of downstream of that area of blockage are all now compromised. And so what the watershed zone is the kind of critical perfusion failure that happens distally to the area of stenosis. And the size of the watershed zone really depends on where that embolus has kind of lodged itself. The larger the vessel it's lodged itself in, the larger the watershed zone area will be, and the larger the area of potential ischemia and damage that can occur. So there are several different types of ischemic stroke that can occur. One is a thrombotic stroke. This is really the most common cause, and these are caused by those atherosclerotic plaques that build up directly in the arteries that supply blood to the brain. There are also lacunar infarcts, and these happen, these are infarcts that are located in single deep penetrating arteries. So these are arteries that are deep inside of the brain. They might develop kind of plaquing or changing that causes the blood flow to stop. They supply areas like the internal capsule of the brain, the basal ganglia, the brainstem. They're usually pretty small. So because of their size and location, lacunar infarcts usually do not cause a lot of cortical deficits like aphasia or apraxia. Instead, they cause what we call lacunar syndromes. So it might be like a pure motor hemiplasia or a pure sensory hemiplasia, or there might be a little bit of dysarthria, like kind of like slurred speech or clumsy hand syndrome. So there's kind of, I guess, like more focal deficits that we see. You can see on the picture on the right, this top picture is actually an example of a lacunar infarct, and you can see these very small areas, they're circled in red, of kind of tissue. It's black, so that's an indicator of infarction. So it indicates no blood supply to kind of that region. But you can see how deep kind of they are in the brain tissue. So it's probably just a single artery that supplied that area that became thrombosed. And the final type is an embolic stroke. And so these are strokes that are happening when a thrombus travels up into the circulation of the brain. So maybe a thrombi coming from the left heart, or something that broke off from an atherosclerotic plaque in the carotids and moved up. So some of the risk factors are patients with atrial fibrillation, patients post-MI, patients with ventricular aneurysms or bacterial endocarditis. In bacterial endocarditis, they get these kind of vegetative like growths on the heart itself. And so what actually embolizes is pieces of those like vegetative growths. It's not really like it's often not like a emboli caused by like platelet aggregation. It's actually like these vegetations from overgrowth from the bacterial infection. The bottom picture shows either a thrombotic or an embolic stroke. And so you can see kind of all along the right side of the brain, all of this kind of darkened area where blood flow is compromised. And now all of that brain tissue has become ischemic. And so that's a pretty large stroke area, watershed zone where we've lost all of that brain tissue. So then we're going to contrast ischemic stroke to hemorrhagic stroke. And so again, this is a far less common type. So maybe 20 to 30% of strokes that we see are hemorrhagic in nature. But these are the type of strokes that are most frequently fatal on presentation. These happen when there's some kind of spontaneous rupture of a cerebral blood vessel. The most common risk factors for having a hemorrhagic stroke are advancing age and a history of hypertension. Also, people at increased risk are those with aneurysms, which we'll talk about, and arteriovenous formations. They usually occur very suddenly and are often accompanied by severe headache and often vomiting. So I mentioned cerebral aneurysm as being a major risk factor for hemorrhagic stroke. And so a cerebral aneurysm is an area in the cerebral circulation. An aneurysm forms where there's kind of that outpouching and weakening of the artery itself. And if that aneurysm ruptures, then someone can bleed and have a hemorrhagic stroke. So the picture over here, you can see there's actually a couple areas of aneurysm. There's kind of one sort of right here, this big outpouching of that artery, and a little bit, kind of right here where there's an outpouching and building up of that dye on angiogram. So these are some examples of cerebral aneurysms. So aneurysm formation right inside the cerebral circulation. So the signs and symptoms we see with a cerebral aneurysm are broken into kind of two time frames. So there are some that occur pre-rupture, so before that aneurysm were to open or break. Small aneurysms are often asymptomatic, so a lot of the time people have small aneurysms inside the brain and they never know they have them. We'll find a fair amount of small aneurysms that are intact, maybe on autopsy, that never give anybody any trouble. But with some larger aneurysms, or sometimes if they develop maybe a small leak, these folks may develop kind of atypical headaches. And sometimes they can develop this sudden onset with nausea, vomiting, and dizziness, especially if they're like close to rupture. Post-rupture, if these things do break open, people usually develop a sudden and severe headache. If that rupture is large, they may collapse suddenly and lose consciousness. They can also experience things like neck stiffness and photophobia because this bleeding can damage or irritate the meninges inside of the brain, and that's what causes this. They experience things like diplopia, which is double vision or blurred vision. They can get pituitary dysfunction that causes DI or diabetes insipidus. And they can also get hypertension and cardiac arrhythmias. This happens because when these aneurysms burst, there's this kind of massive catecholamine release that causes hypertension and dysrhythmia. So aneurysms are often congenital, but things that increase ICP or other environmental factors like cigarette smoking or alcohol intake can increase their chances of rupturing. And the probability that an aneurysm will rupture increases with the size of the aneurysm. And if an aneurysm ruptures, then we get aneurysmal subarachnoid hemorrhage. And so this is bleeding into the subarachnoid space. So you can kind of see that here. This is the subarachnoid space, okay? Right up against the cerebrum, okay? It kind of, this bleeding happens and it like you get blood that sort of starts to infiltrate right into like the meninges and like the tissues right on the brain itself. And that's part of the reason why this kind of causes so much damage, which we'll kind of talk about. But again, causes of aneurysms are things like a congenital defect causing that aneurysm to form in the first place. And then for some reason it ruptures, and they can rupture again if they're really large in size, if there's some sort of acute increase in intracranial pressure, if this person smokes or has severe hypertension, or if they, drink a lot of alcohol. Those are things that can increase that risk. So subarachnoid hemorrhage diagnosis and treatment. So diagnosis is usually done with clinical presentation. So these people may come in either with, sudden and severe loss of consciousness. Someone may report that they had like a headache and nausea right before they collapsed. Or they might come in complaining of severe headache and photophobia and maybe neck stiffness. Those are some pretty common presentations. If that clinical presentation might indicate subarachnoid hemorrhage, then we would do a non-contrast CT scan. And essentially what we're looking for on that CT scan is the presence of blood. You really can't see vasculature, but on CT scan, blood shows up as kind of like a bright white area in the brain, and we would notice it in that subarachnoid space. That would be a good indicator of subarachnoid hemorrhage. You can also do a lumbar puncture if the CT is normal, but you still have high suspicion of subarachnoid hemorrhage. So maybe you've got enough bleeding to start to irritate and damage the meninges, but not enough yet to show up on CT scan. If you do a lumbar puncture, you actually remove some cerebrospinal fluid from the lumbar region of the spinal cord, and then you test it for the presence of red blood cells. And if there are red blood cells, that's a good indicator that there is subarachnoid bleeding occurring. We can also do angiography. If you think back to that picture I showed you where those cerebral aneurysms were showing up, that's cerebral angiography. So we would take a catheter and put it into one of the large arterial blood vessels in the body and inject contrast dye into the vasculature of the brain. And what we're looking for there again is aneurysms and then potentially areas of aneurysm rupture. The treatment for subarachnoid hemorrhage, well, first you want to find and secure the aneurysm to prevent any further complications. So you can either surgically clip them off, you can embolize them to kind of close them, but you need to secure that aneurysm so that it doesn't bleed any further. You can do that again either surgically or what we call percutaneously, where you do it through the blood vessels. Two major potential complications of subarachnoid hemorrhage are something called vasospasm and hydrocephalus. Those are very common complications. If you remember back to how the cerebrospinal fluid flowed around the brain, it flows essentially around in the same compartment as where you now have all of this subarachnoid bleeding. And so that blood starts to compromise that normal circulatory flow of the cerebrospinal fluid through the brain, and it can start to collect inside of the ventricles. And if that happens, it causes this rapid rise in ICP inside of the brain, and that cerebrospinal fluid needs to be drained quickly to reduce that. Otherwise, the patient can have such a significant increase in ICP that they can actually herniate, as we talked about before, where the brain tissue presses through the different openings in the skull. Vasospasm is caused by that irritation of the blood on the vasculature on the brain itself. And so that irritation causes the cerebral blood vessels, the cerebral arteries to spasm. And so they sit and they kind of spasm and close. And as they close, that further compromises the blood flow to the brain. Vasospasm is very difficult to treat. And this is a complication that's associated with a really high incidence of morbidity and mortality in subarachnoid patients. Vasospasm usually develops within 3 to 10 days of aneurysm rupture, and it peaks at about 7 days after. And again, it's this focal narrowing of the cerebral arteries and arterioles that further damages or cuts off blood flow and circulation. So now essentially you get further ischemia and damage to the brain itself. So there's lots of different ways that we try to treat it, and kind of the way we treat vasospasm sort of evolves all the time. We can give medications that reduce spasticity of the veins, like usually calcium channel blockers might help. We used to try to keep these patients' blood pressure elevated to try to keep the vessels open. Um, we need to, kind of aggressively treat and try to keep those vessels from spasming to prevent further damage. So now we'll talk about some specific signs and symptoms of a stroke. So the specific manifestations of a stroke or of a TIA are really determined by the cerebral artery that's affected. So the cerebral artery that is affected will determine what area of the brain is damaged, and that will determine the signs and symptoms that you see. Another determinant here is the amount of collateral circulation. So collateral circulation is like newly formed circulation that happens in the brain that can help to maintain blood supply to areas if larger vessels are broken off. So if there's a lot of collateral circulation, we usually see less damage with a stroke. If there's no collateral circulation, we see more extensive damage. But we often use this acronym called FAST as a way to educate the public on the common signs and symptoms of stroke, because it is really important to initiate treatment as rapidly as possible. So we use the acronym FAST, which stands for FACE, which is facial drooping, A, which is arm weakness, speech difficulties, and finally T is for time, so meaning time to call 911. So if you get facial droop with arm weakness and slurred speech, those are some of the biggest indicators that we have of stroke, and it needs to be managed quickly. So sudden onset focal, so the onset of symptoms is usually sudden and it's focal and usually one-sided. So the face might droop, the arm might become weak, and the speech might become slurred. Other things are unilateral numbness or vision loss in one eye, language disturbances, or sudden unexplained imbalances or ataxia. So those are some other signs and symptoms that you may see besides these kind of three main ones. So some stroke-related motor deficits. So stroke causes a significant amount of motor deficits, so deficits in movement. Motor deficits are actually the most common clinical manifestation that we see immediately and post-stroke. It's usually profound weakness on the contralateral side. So what we mean by contralateral, and you can see that in the picture, this individual had a stroke on the right side of their brain. And so the weakness of the impairments we see are contralateral, meaning the opposite side. So you can see here he's got facial drooping on the left side, contralateral to the damage. So we can see weakness of the face, arm, and legs, again, usually contralateral. That initial weakness and plasticity is often replaced by hyperreflexia and spasticity. That usually happens about 6 to 8 weeks post-stroke. Patients can also get foot drop, which is a contracture that happens in the feet where they stay in kind of the dorsiflexed position. Gait disturbances are also very common. And abnormal flexion at the wrist, elbow, and fingers is also common, again, usually on the contralateral side to the injury. Another really common clinical manifestation post-stroke is stroke-related dysarthria and aphasia. So dysarthria is a problem of articulation caused by the effects of the stroke on the muscles that produce speech. Aphasia is the inability either to comprehend, integrate, or express language. Aphasias can be receptive. We call that Wernicke's aphasia, or they can be expressive, and that's Broca's aphasia. So what I have here is a picture of the brain, and we point out the different areas of the brain that are associated with speech. So Broca's area is associated with speech production, and Wernicke's area, which is right here, is associated with the recognition of speech. And then there's also this kind of area sort of around those areas that are associated with things like the meaning of words, and those can be damaged as well. And so aphasia can happen if any of those areas are damaged. If we just have damage to Broca's area, then people usually have expressive aphasia. So in those patients, comprehension of speech is normal, meaning they can understand what people are saying to them, but they aren't able to produce speech. That's the part that's difficult. And the other piece of that is they really do know what they want to say. They're just not able to produce the words. So that type of aphasia can be very frustrating for the person experiencing it because they fully understand what's happening. They just can't get the words out. The other type of aphasia is what we call receptive aphasia or Wernicke's aphasia, where we have damage just to Wernicke's area. And in those people, in receptive aphasia, there's an inability to comprehend the speech of others, and it can be both written speech and spoken speech. So they can produce, speech, but they can't understand what someone else is saying. So if you're working with someone with maybe Wernicke's aphasia, you might ask them a simple question. They don't understand it. They may respond to you, but their response will be completely uh, not associated with the question you asked because they didn't understand it. The other thing to understand about aphasias is if both of these areas, if there's a really large area of stroke and it affects both Broca's and Wernicke's areas, that aphasia can be what we call global, where someone both cannot produce speech and can't understand it. Hemi-neglect is another common clinical manifestation that we might see post-stroke. Hemi-neglect, or what we call hemi-inattention. And hemi-neglect is the inability to attend and react to stimuli from the contralateral side. So hemi-neglect, if someone has a right-sided stroke, hemi-neglect would happen on the left. So people may not visually track or reach to the neglected side. So if you approach somebody from the neglected side, so if they have left-sided neglect, if you come at them from their left side, they may not really see or attend to you being there. If they have a plate of food in front of them, they may not eat anything on the left side because they can't attend to it. They may neglect limbs on the left, even though they have normal motor function. They may not shave or wash or comb that side of their face because they're not seeing it or attending to it. So the picture here shows what a person who was asked to copy a picture, how they would do that if they had neglect. So this is the model, right? So we gave people maybe a picture of a clock and we're like, okay, draw this. And you can see they only draw one side of the clock, right? They just draw the right side. So they have some kind of left hemi-neglect. Same with the house, right? They only draw one side, right? Here's our flower. They only draw one side. So left-sided hemi-neglect, right? Probably a right-sided stroke. Other deficits are things like apraxia, agnosia, memory loss, behavioral syndromes, and depression. Apraxia happens because motor units are normal. Remember we talked about this with motor control. The motor units themselves are normal, but because there's a stroke or potentially damage to the motor cortex in the brain can't make them do what they want. So they lose that kind of coordinated control. Agnosia is the ability to identify objects. So if you put a common object in front of somebody, they might not be able to tell you what it is, even if their speech is intact. There can also be sensory deficits. Again, those are usually contralateral, so on the opposite side. So they may they might have sensory impairment, and they often get things like visual disturbances too. So maybe blurred vision or double vision are pretty common as well. So diagnosis and treatment of stroke. So we said that time is of the essence here when someone comes in with those common stroke symptoms. And so if someone is coming in that way, really the first thing we do is really ask history. And we're doing a really quick abbreviated history to determine the type and the severity of the deficits. And also at the time of onset is extremely important here. And then their next immediate stop is to CT scan. And the reason we send people with stroke symptoms to CT scan is to determine whether this is an ischemic or a hemorrhagic stroke, really truly to rule out hemorrhage. A CT scan doesn't show ischemia initially. The initial CT scan of someone having a hemorrhagic stroke will look relatively normal, but what we won't see is blood. And that's really what we're looking for, because in ischemic stroke, what you're going to typically do is give some sort of thrombolytic or blood thinning drug. You don't want to do that if someone's having a hemorrhagic stroke obviously, because it'll make it far worse. So they go to CT scan. If there's no bleeding, we rule out hemorrhage, and then we go through the next kind of pieces of treatment in the ischemic stroke. I'll also mention here that MRI can show ischemia initially, but usually we don't do that step. Initially, we just rule out hemorrhage and kind of keep going with treatment. We can also do CT angiography if we're worried about vascular abnormalities. So maybe somebody comes in with stroke symptoms and we do see hemorrhage. Then we can do a CT angiography to look and see where those vascular abnormalities are coming from. If ischemic stroke is what we're seeing occurring, then we can give thrombolytic drugs. We can either give them intravenously, where they'll go through the entire system, or we can give them intra-arterially, where we kind of inject them right at the site of stroke. We can also do something called catheter-directed mechanical clot disruption, where we put a catheter right inside the cerebral vasculature and kind of break up or grab and pull those clots out. Those are some of the ways that we can sort of restore blood flow very quickly to someone having an ischemic stroke. Because the goals of treatment here are salvaging brain tissue, as well as preventing any secondary strokes in an attempt to minimize any long-term disability. The faster we can get those vessels open in the case of an ischemic stroke and prevent the closure of any more vessels, the more, the better outcome and the less disability we have in our patient. So really working towards that rapid reperfusion in the case of ischemic stroke. After someone has a stroke, post-stroke care is also very important. So things like rehabilitation and then preventing future strokes. So whether it's making sure they're maintained on anticoagulation, keeping their blood pressure down, using, antihyperlipidemics, those kind of things. So finally, we're going to talk about seizure. A seizure is an abnormal behavior caused by some sort of electrical discharge from neurons in the cerebral cortex. They're usually a discrete clinical event associated with signs and symptoms that can be quite variable, and the variability is really caused by the site and the amount of neuronal discharge in the brain. So the signs and symptoms that you see in a seizure are determined by the area of the brain where the seizure is coming from and how large that area of seizure activity in the brain is. So manifestations are usually sensory, they can be motor, they can be autonomic, or they can be psychic phenomenon. So some people have kind of that classic like shaking motor movement. Some patients just like maybe have visual aura. Some people have just like a sensory seizure where like they smell something or hear something or see something that's abnormal. Lots of different ways that seizure activity can manifest itself. They may be caused by these alterations in cell membrane permeability or changes to ion distribution across the cell membrane. Some people have just seizure disorders where they're kind of idiopathic in nature. We don't know why they're having seizure activity, but most commonly seizures occur during any serious illness or injuries that are affecting the brain. So anybody with any of those brain injuries that we talked about, whether they're stroke that are ischemic or hemorrhagic, brain tumors, traumatic injuries to the brain, any infections of the brain, drug abuse that affects the tissues in the brain, congenital deformities, any of those things can cause seizure activity as well. And so it's not uncommon for people who have known brain injuries to also receive seizure preventative medications. So we might load them with something like Dilantin or Keppra or some kind of medication to prevent seizure activity, even if they haven't had any yet, again, because their risk is so high. So with diagnosis and treatment to diagnose seizures, we take a good history and do a neurological exam. We can also do lab studies looking for potential reasons why someone might be having seizures, like whether it's an electrolyte imbalance or, a drug or a toxin, something like that. We can do brain imaging to look for structural defects. We can also do EEG, which is electrical, looking at the electrical activity of the brain. Treatment is to try to protect our patient from injury during the seizure and to also stop the seizure. So we can use things like benzodiazepines are really common, like Valium injections or Ativan injections to try to stop that seizure. And then using seizure precautions like maybe padding on the bed or if we're out in the field, bringing the patient kind of to the ground so that they don't fall and injure themselves, keeping them away from any like items that can injure them, maybe like putting something under, supporting the head, anything we can do to protect them from injury. We never put anything though in the mouth when someone is seizing. We just kind of, keep them away from anything that could cause injury and then try to stop the seizure. And then you want to figure out if there's an underlying cause and treat that to prevent any activity in the future. And we also commonly use anticonvulsant medications that kind of reduce that kind of electrical discharge in the brain, usually by changing maybe the ion travel across those membranes, something to kind of chill out those membranes so seizure activity doesn't continue to occur. The last thing I'll mention is something called status epilepticus, and this is continual seizures that we're not able to stop or that won't stop spontaneously. These are a medical emergency because if they're untreated or this is not stopped, it can lead to death because of respiratory failure. While someone is seizing, they are often not breathing, especially if that seizure activity is severe. And so if we can't stop it, they can go into respiratory failure. So treatment here would be supplying appropriate life support measures, trying to rapidly give medications to control that seizure activity. So things like intravenous diazepam or lorazepam, those are our first line treatment. And the prognosis here is really related to like the underlying cause as well as the duration of the seizure themselves. So sometimes when status epilepticus occurs, it's because there's some kind of underlying thing, brain tumor, whatever it is, that's really severe in nature. And if that's the case, the prognosis is just generally poor because of both issues. But if we can stop the seizure activity relatively quickly, and figure out the cause, the prognosis can be okay.